So as many of you know, if we sort of think about delirium sort of diagnostically, what this is in some ways acute changes or acute failure of the brain to function appropriately. And this is oftentimes an acute change in mental status. And we define this as impairment primarily in the ability to have attention and concentration. So when you have a patient in the room that you're seeing that can't pay attention to questions, can't follow, like providing repetitive statements, like telling you the months of the year, say backwards, but can also have components where there's changes in their ability to be oriented to the date, time, place, what's happening, focal changes in their cognition, fluctuations in their consciousness. There can be psychosis or reality testing abnormalities like hallucinations or delusions, as well as behavioral changes that can be either motor changes like agitation, psychomotor slowing, as well as sometimes other movement symptoms or other focal neurologic deficits. But the primary thing to remember is that this is an acute change. So this isn't somebody who has a chronic neurodegenerative disorder. It's somebody who was doing fine the day before or prior to, say, a surgery, and then all of a sudden is having acute mental status changes. These can fluctuate. There's sometimes attending phenomena that happens where you may go in the morning and the patient's perfectly alert and oriented and able to have a conversation. And then you round a couple hours later and the patient's now agitated, yelling, screaming, and psychotic. In general, there's a medical reason that this is happening. And as I'll talk about in a minute, generally there are things that we can reverse. Say, for example, a urinary tract infection or pneumonia causing hypoxia leading to a change in mental status. But sometimes these aren't fixable medical etiologies. And again, delirium is not dementia. So dementia is a chronic change in mental status, chronic changes in reality testing, whereas this is an acute change. So I want to just define how we sort of think about this in different types of delirium. And a lot of this is based on sort of motor changes and behavioral changes for a patient. And so many of us have experienced these three different types of subtypes, particularly the hyperactive patient who's more the agitated, psychotic. They're usually the ones that draw our attention, or we get phone calls from or pages from the nurses to help with managing symptoms. More frequently, there may be hypoactive delirium, or a patient who post-operative day 2 or 3 is sort of withdrawn, not participating and getting out of bed, not eating much, will seem depressed, but really when you talk to them, they can't pay attention, they're confused, and we tend to see more commonly a hypoactive subtype. And then some people may fluctuate between these motoric subtypes and are referred to as a mixed delirium. And as I mentioned, the most prevalent here is oftentimes the hypoactive subtype, and unfortunately is also the most, has the highest risk of mortality. One, because we oftentimes don't identify it, but there's something about the way the brain changes in this particular subtype that increases the risk of dying, particularly in the 3 to 6 months after this develops. And in particular, there's some prognostic implications for patients when they develop delirium that may lead to some cognitive impairment that may be permanent. And what we oftentimes don't talk about, and I want to focus on for this discussion, particularly as we talk about symptom management of delirium, particularly in patients with advanced illnesses, say, for example, cancer, heart failure, COPD, and when they're approaching the end of life, is that the change in people's mentation is again a sign of end organ dysfunction. It's a sign of the brain failing to work properly. And this can have prognostic implications. For a lot of patients that come in, again, I mentioned like things like a urinary tract infection or pneumonia that leads to hypoxia and some mental status change. If there's an underlying medical etiology that we can fix, oftentimes the delirium gets better, and this is a reversible form of delirium, and we may be able to fix that. Commonly, for those of us who work with patients with serious illnesses, we run into deliriums that may be irreversible, and I'll talk about a case specific to this in a moment. But some ways to think about this is there are diseases that cause end organ dysfunction in the brain, that cause brain changes that lead to poor perfusion, where if we can't fix the underlying medical etiology, then that end organ dysfunction, that brain failure doesn't get better and it's not fixable. And for some patients, that irreversible delirium is oftentimes a sign that we're transitioning to dying. And so some phrases in the literature, what we'll talk about is people refer to as a terminal delirium, which is generally an irreversible delirium where we have signs that people are starting to actively die. People aren't eating or drinking, they're bedbound, disease progression, signs like hypotension that people are starting to progress to dying. And so we definitely can't fix this. But those patients who are having an irreversible terminal delirium may be very symptomatic, particularly if they are having more of a hyperactive type of delirium. And so there are symptoms that we may need to palliate that can be very distressing to the patient, maybe distressing to family and caregivers, that require more aggressive interventions at the end of life.